I really enjoyed all of your talks this morning. They were very compelling. So I have a question as a 56-year-old surgeon still in practice. You know, your brain starts to get lighter at the age of, I believe, 22. You can't process all the information that comes in as quickly as you did when you were in college and medical school, and that's all proven. And if you continue to use your brain, you create scaffolding, which means that even though your volume loss goes down, you get to the answer faster. Is anyone even looking at, when you look at adoption of any of these technologies, especially in electronic records, is anyone actually looking at the age? You know, are you designing it for those, you know, you hear this all the time, oh, your front end, they're all good on Facebook. They're gonna really be good with the EHR. That is not true. So is anyone actually looking at their end user by age?
No. So the question was, when we look at age-related ability to adapt to new technologies, is anyone thinking about that? And, you know, I understand that situation. You know, I went through pilot training when I was 30, and a lot of people looked at me as like, oh, I was trying to teach an old dog new tricks at age 30 when I'm up against people that are 21. And so I appreciate that issue, but I can tell you, I'm not aware of anyone looking at that issue, and I think it's important. I think that's also on the patient side. You know, a lot of this new technology, we're leaving a huge swath of our patient population vulnerable because we're going to these digital solutions. And I know, you know, people in my family are not going to adapt to it. And so does that mean they're left out and we're compromising their access to care? So I think it's a great question. I think we do need to look into it.
Well, that's a great question and a great answer to that. Taking kind of a cue from Dave's experience as a pilot, cognitive overload and is a well-established limitation of physician and electronic health record interface. Obviously, that holds true for the patients too. And that is the reason why physicians struggle interacting with the computers. And the National Institute of Standard Technology, NIST, has released some basic playbook guidelines about electronic health record architecture. But to your point, there's actually no evidence in terms of best user interfaces or efficient user interfaces for evolving needs. That's another big unmet need. Is the current interface was designed for paper records and interactions that were 20, 30 years ago. Current interactions with all the remote monitoring and things are a different beast altogether. And I think that's the
Thank you for this fascinating presentations this morning. Dr. Dave, you talked about a journal club. I'm a physician, EmergeDoc. I run a tech company. And one of the things that we're fascinated with is that rapid learning systems that AI can create around knowledge, they're not publishable. And so, like, as a physician, I now have knowledge in my company that's the property of a corporation with investors and all the other obligations, but the academic in me wants to share some of our insights so that people are not recreating the wheel in every hospital. So how do you think, I love the idea of a journal club, how do you think we can evolve our academic knowledge producing and sharing tools to meet the reality of this rapid, you called it real-time evidence process? Fascinating.
Well, I haven't thought that far ahead yet, but I see your point, and then I see this dilemma because there's a lot of companies that have these technologies, and you know, the people that I'm working with, you know, there have been conversations about maybe we need to make it transparent, maybe we need to make it available to everyone, but as long as there's money on the table, there are going to be people that are not going to want to share, and so maybe public policy is the way we go with this. I think, you know, you can't legislate ethics and all of those things, but I think maybe there's an opportunity for legislation that provides the right incentives, as our keynote was talking about. It's not that incentives don't work, it's that they work too well. And maybe that's the opportunity.
Yeah, I have a question about the codes. I really appreciate you putting up all those codes. And one of my questions, it's kind of a three-part question. One of my questions is, are people actually getting money now for those codes? And another question is, there are new codes now for coaching, and a lot of the digital health products include some kind of online app and maybe a virtual or a real coach. And could you say a word about those coaching codes and whether you think they'll be useful in the setting of these digital health applications?
I don't know too much about the digital health codes. I do know that when you have let's say a given workflow, it may seem like it applies to multiple different codes, and then it gets very confusing as to which one to pick. And I've seen some more, kind of depends on the billing department at any given place. Some of the more conservative, maybe I'm going to say conservative billing groups at hospitals will tend to pick codes that have been around longer because they just have a little bit more track record, but it's very much chicken or egg because new codes are out there not only to facilitate reimbursement to healthcare providers, but also to track utilization, and codes will die if they don't get utilized. So it's kind of use them if you think that you believe in them and they're worth the time to be tracked by payers. The other thing that I've noticed while I was at AliveCor was that the remote patient monitoring codes were overwhelmingly used by primary care and psychiatry and not cardiology. So the cardiologists were looking towards other codes like interrogation of pacemakers or doing other or using Zio patches. They were doing the very same thing but using other more established codes for that. But primary care has now embraced these codes because they didn't have anything like this before. And payment was, I think, more consistent amongst Medicare because they're the ones who came out and said, let's use these codes, and the commercials are following suit.
Good morning. Thank you so much for great talks. I had a question regarding the nudge theory, and where I work in digital health, but also have a clinical practice. And where I'm practicing, I notice now that many of the tests that I'm ordering that are listed as you've listed now have dollar signs next to them, with one up to $4 signs, letting us know the expense of a test. And that wasn't something that you had mentioned. I'm just wondering whether that's a valid way of acknowledging the cost associated with this, and whether we're making any difference by making physicians aware of costs. This is something new that I'm seeing in an Epic-related medical record system. And then I had a question for Dr. Prakash as well. I'm also a pilot, and part of the ways that pilots do things is routinization of checklists and checklist manifesto, if you will. And I'm just wondering if you might comment on how an AI a based approach, which can kind of disrupt some of that, and you have to learn new checklists, might affect doing new things. But I'm just wondering if you knew anything about the financial aspect as well.
Oh, that's a great question, because in the earlier part of my talk, I did visit a number of randomized control trials that have not shown any association between price display and healthcare quality as measured by the efficiency domain. That has a lot of implications. Part of the reason is that we learn differently from electronic screens, so maybe there is no learning at all that happens when we look at electronic screens. There was a big randomized control trial looked at school kids in Norway. 10,000 were randomized to paper materials and 10,000 were randomized to electronic screens. The paper cohort did very well after adjusting for socioeconomic and all that stuff, so maybe that's there. And two, then there is this concept of the patient struggling with a lot of medical problems, and maybe the dollar sign doesn't make sense to me. Unfortunately, the problem with vendors is that they're releasing all these interface adoptions, interface tweaks, without any awareness of the randomized trial data that's out there. And I think that's where to Dave's point, if this is not really directly related to artificial intelligence, but who is curating that evidence? Who is curating those user interface tweaks? On the contrary, price display has been shown in the subspecialty domain to increase healthcare costs. Because if someone comes to me with a migraine that has already been seen by 5 specialists, I'm not going to be worried about the dollar cost of the triptan in front of me. I'm going to go for the best out there. And again, physicians are heuristic animals. They don't have time to sit down and go rationally.
So I think it's a step in the right direction for certain. I think not only for physicians, but I think for patients. I think as we move to a much more patient-centered approach and patients become much more aware of the costs associated with different procedures, different treatments, they will actually put pressure on the clinician to consider the different options. I think that when physicians are aware of the price differences between different options, they do take into consideration. So the fact that we've even moved in that direction at all is a step in the right direction.
Actually, very good point that you make, because I didn't talk about that. Patient-centered price display has been shown to be consistently resulting in improved healthcare quality, whereas the physician is kind of all over the place.
So to answer your question, I was actually part of a startup where we were trying to bring voice-activated heads-up displays to help surgeons run checklists in the OR. But to a lot of the problems you described, the misalignment of incentives in terms of who uses it, who's going to benefit from it, and who's going to pay for it, we tried, but it didn't go very far. But I think there's another opportunity with AI here, and I'll use the example of autism in pediatrics. There was the guideline change recently that said early intervention is recommended, but it was the first change to the guideline in 12 years. And so what I see is instances where doctors are following the guidelines, having good and bad outcomes. There are also instances where doctors are not following the guidelines and sometimes having even better outcomes or worse outcomes. And so how can we use the data, leverage the data to start with the target and work backwards, find out what's working and what's not for which patients, and then perhaps redesign the guidelines appropriately, and maybe we can shorten that lag.
Well, thank you very much. This was a great morning session. Thank you all the speakers for your insight and thoughts in your presentations today. Now is the time for break. You have some food and drinks out there. Relax a little bit. I just want to mention that we do have 2 great breakout sessions coming out today, on social media and medical device. So you can see that on the screen. Also, people who do need CME credits, please go to the registration desk and make sure that the CME checkbox is checked off if you haven't already. Great, thank you so much.